बता देना मुझे कब स्टार्ट करना।
जी जी जी, आप स्टार्ट कर सकते हैं। हो गया, हो गया सर, डन।
So, very good evening to all of you. I hope I am audible, visible to all of you. Very good evening. Sorry for a little late starting this. So, very good evening to all of you. Are you all able to see me? Are you all able to hear me? So, welcome to this session where we will be discussing 25 important pediatric questions from for your upcoming January FMG exam. And I have carefully selected the topics for these questions, keeping in mind your FMG exam. So I believe that these are the topics which are the important topics for your exams, and at least these are the topics that you should definitely go through during your final revision when you're preparing for your exams. So with this, I will start. Thank you very much. A few happy birthdays. So it is not my birthday, but anyway, I take that as a compliment, and I will start with my class. The first question is: all of the following statements about newborns are correct except. So he's asking all of the following statements are correct except. So he's asking which of the following statement is not correct. So the first choice is, or first option is, resuscitation is needed in most newborns at birth. The second option is late umbilical cord clamping is preferred at birth. The third option is meconium is green in color and is usually passed by 24 hours of birth. And the fourth option is that the mode of feeding of a newborn should take into consideration the gestational maturity of the newborn. So which you feel is basically an incorrect statement. He's asking all of the following are correct statements except. So he's asking which of these is not a correct statement. So there are some A's, some B's, some C's. Let me tell you, late umbilical cord clamping is preferred at birth is actually a correct statement. This is not an incorrect statement. It's a correct statement. Usually when a child is born, the cord clamping is done after birth. And initially it was an early cord clamping that was recommended. But now most of the guidelines recommend that the cord clamping should be delayed till 30 to 60 seconds of birth. So this is not an incorrect statement. It's a correct statement that late cord clamping is recommended. Option C is meconium is green in color and is usually passed by 24 hours of birth. Now this again is a completely correct statement. There is nothing incorrect about this statement. It is a completely correct statement. Meconium, that is the first stool of a newborn, is usually passed within 24 hours of birth, and it is a stool which is green in color. Mode of feeding of a newborn should take into consideration gestational maturity. Definitely yes. So as I have told in my classes, 34 weeks plus babies are given breastfeeds. But babies who are born earlier than 34 weeks are not given breastfeed. So this is again an incorrect statement. So the only incorrect statement according to me is choice A. So those of you who have given choice A as the correct answer are correct. Actually speaking, when a newborn is delivered, almost 90% of the newborns usually require no resuscitation at birth. So basically, what does resuscitation mean? Resuscitation means child should be given, say, tactile stimulation, ambu bags, intubation. This actually is required in just 10% of total cases. So he's saying resuscitation needed in most newborns at birth. This is actually an incorrect statement. Resuscitation, as you can see, is required in only 10% of the cases. 90% of the newborn cases do not require resuscitation. So when a newborn is delivered, and then we see whether the newborn is a term newborn, he is breathing regularly, and he is having a good tone. So if all of these are yes, that means this newborn baby does not require resuscitation. And this is seen in almost 90% cases. So you just hand over the baby to the mother. Resuscitation means child being given ambu bags, child being given tactile stimulation. That means there is something wrong with the baby. And this is required in only 10% of the total cases. So resuscitation is required in only about 10% of the cases. 90% of the cases do not require resuscitation after birth. And first 1 minute time, yes, is the golden time for resuscitation. That is the time when you need to decide whether you have to start with ambu bags, whether you have to give tactile stimulation, or whether you should move on to chest compression or to intubation. All of those are decided in the first 1 minute, and then you subsequently keep on moving further in resuscitation steps according to the response of the baby. So there have been some who have given correct answer A, but most of you have given, yes, most of you have given a correct answer A. There have been some who have given a correct answer A, but B, C, D are incorrect options according to me. These are the babies, B, C, D are the babies which are totally true for these babies. So late cord clamping, yes, it is done. Meconium, yes, it is green in color. And mode of feeding, yes, it should be according to the gestation maturity of the newborn. Coming to question number 2. A 6.5-year-old child is being investigated for short stature. So the child is 6.5-year-old. The child's upper segment to the lower segment ratio is 1.6 at birth. Sorry, at this time. That means at 6.5 years, the child's upper segment to lower segment ratio is 1.6. The family history of the child is normal and is not contributory to the case. Bone age of the child, now this is very important, bone age of the child is delayed. So bone age is not normal. When the bone age is not normal, a familial short stature is ruled out. Because familial short stature, bone age equals the chronological age. So familial short stature is already ruled out. Plus family history is normal. That means there is no history of short parents in the family. So he is asking the most likely cause of short stature among these is. So according to you, the correct answer is constitutional delay. But please see this. You have missed out this 1.6. You have missed out this 1.6. Upper segment to the lower segment ratio at birth, I have told in my classes, is 1.7:1. And this ratio goes on changing with age. So this ratio becomes, at 1 year, it becomes 1.6:1. At 6 years, it becomes 1.1:1. And between 7 to 10 years, it becomes 1:1. So please see what is the upper segment to the lower segment ratio at 6 years. At 6 years, the upper segment to lower segment ratio is 1.1:1. That means the upper segment is 1.1 times the lower segment. But in our case, the upper segment to lower segment ratio for a child who is 6 years of age, 6.5 years of age, is 1.6. Ratio should be 1.1. Here it is 1.6. So is this a proportionate short stature or disproportionate short stature? Now you answer. Is it a proportionate short stature or disproportionate short stature? It is a disproportionate short stature because the upper segment to the lower segment ratio is not matching with its age. At 6 years, it should be 1.1:1. But in our case, it is 1.6:1. Please identify the clues that are given in the question. Every question is not so simple. There are clues in the question that you have to identify. So this cannot be a constitutional delay because constitutional delay is not disproportionate. And yes, there are students who have given that what are the causes of disproportionate short stature. CAR, CAR. So congenital hypothyroidism, achondroplasia, rickets. Now you see congenital hypothyroidism, achondroplasia, rickets. Is there any option? Yes, one option is congenital hypothyroidism. आवाज गूंज रही है तो गूंजने दो, पर अभी क्वेश्चंस की तरफ नोटिस करो गुरुजी. अभी जस्ट नोटिस ऑन द क्वेश्चंस, राइट? So what I'm trying to say is that the upper segment to the lower segment ratio should be 1.1:1. But the ratio is, in this case, 1.6:1. So this is a disproportionate short stitcher. And if it is a disproportionate short stitcher, it cannot be a constitutional delay. Familial short stitcher already ruled out. So the only type of short stitcher that can be possible in this case is CAR, which are causes of disproportionate short stitcher. Which are CAR? Congenital hypothyroidism, achondroplasia, and rickets. Yes, so C is therefore the correct answer, congenital hypothyroidism. So now question is, why not D, growth hormone deficiency? Because growth hormone deficiency, endocrinal disorders is again proportionate short stitcher. Remember CAR, disproportionate, FEET, proportionate. FEET, and E was endocrinal disorders. Growth hormone deficiency leads to proportionate short stature. Our case is disproportionate short stature. So I hope you have all understood why C is the correct answer. D is not the correct answer. A is obviously not the correct answer. B is not the correct answer. The clue here is that the child has a disproportionate type of short stature. Coming to question number 3. Mark out the incorrectly matched. So which of these statements is incorrectly matched? Milestone which is incorrectly matched with its age of first appearance. So you wanted questions on milestones. Now here is, it's a very important topic for your exams. So which is an incorrectly matched milestone with its age? So they are saying child transfers objects at about 6 months. Then they are saying the child shows the pincer grasp at about 9 months. Then they say the child has the tendency to speak in sentences at 12 months. And then they are saying the child climbs stairs at the age of 24 months. So which of these is incorrectly matched? Not correctly matched. Yes, correct. Answer is yes. Answer is C. C is incorrectly matched. Child starts speaking in sentences from 2 years of age, which means 24 months of age. The child does not start speaking in sentences from 12 months of age. The child starts speaking in monosyllables at about 4 to 5 months. The child starts speaking in bisyllables at about 9 months. The child starts speaking in jargons at about 15 months. And the child starts speaking in sentences at 2 years of age. So sentences is 2 years of age. Sentences is not 12 months. Sentences is 24 months. Rest, all of them are correctly matched. The child transfers objects from one hand to another hand. Correct. It is at 6 months. Ulnar grasp appears at 6 to 7 months. Radial grasp appears at 8 to 9 months. Pincer grasp appears at 9 months. And a mature pincer grasp appears at 12 months. And the child starts climbing stairs at 2 years. So all of these are correctly matched. The only thing which is incorrectly matched is that the child starts speaking in sentences at 12 months. No, it is at 24 months. Coming to question number 4. Question number 4 says a child with irritability, diarrhea, growth retardation, alopecia, and periorificial dermatitis. Now here again, this is the clue, periorificial dermatitis. What is periorificial dermatitis? Periorificial dermatitis means a dermatitis or redness or scaling around the mouth and the nose. Periorificial, it means around the mouth and the nose, includes these nasolabial folds. These are the nasolabial folds. So the dermatitis is surrounding the nasolabial folds. In fact, if I am not wrong, 2 years back or 3 years back, this question was asked in the FMG exam in the form of an image-based question. They showed a child who had redness and scaling around the mouth and the nose. This is typical of which type of deficiency? Yes, this is typical of zinc deficiency. I told you zinc deficiency leads to DAD, that is diarrhea, alopecia, and dermatitis. Diarrhea, alopecia, and dermatitis. So zinc deficiency leads to a condition which is known as acrodermatitis enteropathica. Acrodermatitis enteropathica. Zinc deficiency leads to a condition which is called as acrodermatitis enteropathica. So diarrhea is present in our patient. Alopecia is present in our patient. Dermatitis is present in our patient. So many clues they are giving to you. This is a case of zinc deficiency. Copper deficiency leads to which condition? Copper deficiency leads to Menkes disease. It's a disease which is a neurological disorder, which is associated with characteristic hair changes. Similarly, selenium deficiency is associated with Keshan's disease, which is a type of cardiomyopathy. So these are the disorders which are associated with specific deficiency of the micronutrients. Yes, means kinky hair disease. Coming to question number 5. A 2-year-old newborn is brought to the emergency. A 2-day-old newborn is brought to the emergency with increasing breathing difficulty, starting immediately from birth, and a scaphoid abdomen. So what is the clue here? The clue here is scaphoid abdomen. Scaphos means boat-shaped. Scaphos means boat-shaped. So the child has a boat-shaped abdomen. A newborn presenting with the breathing difficulty and a boat-shaped abdomen is indicative of which type of disorder in newborns. I have explained this in my classes. Which is the disorder the child is suffering from if a newborn immediately after birth has a scaphoid abdomen, a boat-shaped abdomen with breathing difficulty? Yes, it is a diaphragmatic hernia. Yes, very good. It is a congenital diaphragmatic hernia. It is a congenital diaphragmatic hernia. Just hold on for a second, please. So this is a case of a congenital diaphragmatic hernia. And in a congenital diaphragmatic hernia, as I told you, there are abdominal contents that herniate into the chest cavity. So the most common cause of death in these children is actually a pulmonary hypoplasia. The lungs do not grow because the lungs do not have the space to grow. And as you are correctly saying, in these cases, bag and mask ventilation is contraindicated. So the first treatment of these cases, congenital diaphragmatic hernia, is intubation. After intubation, then nasogastric tube insertion. Then ventilation. And finally, the child should be taken in for a surgery. Now, because all the abdominal contents have herniated into the chest cavity, that is why the mediastinum shifts towards the other side. So that is why in our patient you can see it is written the heart sounds are displaced towards the right because all the abdominal contents have entered into the chest cavity. So the contents have obviously moved towards the right. So therefore, which is contraindicated in these cases? Bag and mask ventilation is contraindicated. He's saying all of the following should be part of the initial management, except which should not be part of the management. You will never do ambu bags in these cases. Because if you do ambu bag in these cases, you will push air into the stomach. And remember, the stomach right now is not in the abdomen in these cases. It is in the chest cavity. Because the abdominal contents have herniated into the chest cavity. So bag and mask ventilation is actually contraindicated in these cases. What are the indications in which bag and mask ventilations are done in newborns? Bag and mask ventilation. What are the indications for bag and mask ventilation in a newborn? Indications. So one indication of bag and mask ventilation in a newborn is any newborn who is having apnea. And the child has not come out of apnea despite being given tactile stimulation. So after birth, if a child is in apnea, we first give tactile stimulation. But if the child does not come out of apnea despite giving tactile stimulation, then bag and mask ventilation is given. The second is any newborn baby who is either having apnea or is having a respiratory distress after birth, say gasping after birth, with important thing is heart rate less than 100 per minute. Now this is very important. Heart rate less than 100 per minute is an indication for bag and mask ventilation. Last year it was asked, heart rate less than 60 per minute is an indication for chest compression. But heart rate less than 100 per minute in a child, in a newborn who is either gasping or is in apnea, despite giving tactile stimulation, the child should be started on bag and mask ventilation. Important indication is that the child's heart rate should be less than 100 per minute. These are the indications for bag and mask ventilation. And what is the contraindication for bag and mask ventilation? One of the most important contraindication for bag and mask ventilation is a congenital diaphragmatic hernia. That is one of the most important contraindications. So please remember here, what is the treatment that should not be given? The treatment that should not be given here is bag and mask ventilation because this is a case of congenital diaphragmatic hernia. And as I told you, in congenital diaphragmatic hernia, bag and mask ventilations are contraindicated. Coming to question number 6. Question number 6 says, a malnourished child is being evaluated in the pediatric ward. So there is a child who is a malnourished child and is being evaluated in the pediatric ward. The medical students are interested in knowing the best method. So the medical students are interested in knowing the best method to evaluate acute malnutrition in the child. So they want to know what is the best method to evaluate acute malnutrition in the child. So they are saying which is the best possible criteria for diagnosing acute malnutrition. Now, as you know very well, there are two types of malnutrition. One is acute malnutrition and one is chronic malnutrition in children. So when we say which markers can be used for acute malnutrition, one is weight for age, and there is another marker which is known as weight for height. But for chronic malnutrition, there is only one marker mainly, which is height for age. So for acute malnutrition, the best marker is weight for age and weight for height. So two best markers. Now students are often confused here What is weight for height? Weight for age is weight according to age. But what is weight for height? Remember, we used this term weight for height when we were talking about severe acute malnutrition. So one of the criteria for severe acute malnutrition is weight for height less than 3 standard deviations from the expected. So now the question here is that what is weight for height? So weight for height is weight of a supposedly malnourished child compared to the weight of a normal child with the same height. So you are comparing the weight of two children, one is malnourished, one is normal. And what is common between the two? The same height. That means the weight of a child may be different from the weight of a normal child, but the height of this malnourished child is the same as the height of a normal child, which means this malnourished child does not have chronic malnutrition because height is not affected. So weight for height means only weight is affected, not height, because the height of both children is the same, malnourished child, normal child. So among weight for height and weight for age, weight for height is actually considered as the best marker for acute malnutrition, best marker. Weight for age can also be used, but as you know, weight is affected in chronic malnutrition also. So the best marker for acute malnutrition according to me should be weight for height, which is better than weight for age. Height for age can only be used in chronic malnutrition, but weight for height is a better marker according to me than weight for age. Therefore, for me, the answer to question number 6 should be A. I'm not saying that weight for age cannot be used. This I'm not saying. Weight for age can also be used for acute malnutrition. But his question is, which is the best possible criteria? Which is the best possible criteria? So best possible criteria according to me is weight for height. Now suppose they ask you, which is the only marker which can be used for acute malnutrition and chronic malnutrition in children. So which is the marker which can be used for acute malnutrition and chronic malnutrition? That is one marker which can be used for acute also and chronic also. Now you see here, weight for age can be used in acute, but it cannot be used in, weight for height is used in acute, but it cannot be used in chronic. Because height is the same in acute and chronic malnutrition. Chronic malnutrition, height is affected. In acute malnutrition, height is not affected. So weight for height can be used as marker of acute malnutrition, but it can never be used as a marker for chronic malnutrition. But weight for age, weight gets affected in chronic malnutrition also. So weight for age can be used in acute also. It can be used as chronic also. Although in chronic malnutrition, the best marker is height for age, but weight for age can also be used as a marker. So if someone asks you which is the marker for acute and chronic malnutrition in children, it is weight for age. So best marker for acute malnutrition, weight for height. Best marker for chronic malnutrition, height for age. But which is the only marker which can be used in acute malnutrition also and chronic malnutrition also? It is weight for age. Weight for age is the only marker which can be used in acute malnutrition also and chronic malnutrition also. Mid-arm circumference जो है malnutrition का marker होता है, but usually it is not considered the best markers. The best markers are always weight and height. Mid-arm circumference, the major advantage is that mid-arm circumference is age independent. So it can be used when a large number of children are being evaluated. तो आपको एक एक बच्चे की age की जरूरत नहीं होती. You do not require to ask each child's age. So when a number of children are being evaluated for malnutrition, then the best marker possibly can be mid-arm circumference. But usually within a group of children which is limited, Weight and height are always the better markers and more commonly used markers than mid-arm circumference. And mid-arm circumference plus, as I told you, is for SAM also, severe acute malnutrition also. And if nothing else is mentioned in the question, then weight for age is the best. Yes, if nothing else is mentioned, then weight for age. Weight for age is never the best marker. No, 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 no. This is never the best marker. The best marker is weight for height. Weight for age is the best marker for acute also and chronic also. But if you are asked only best marker for acute malnutrition only, then weight for height is obviously better than weight for age. Coming to question number 7. In a child with severe acute malnutrition, which of these options is an indicator of kwashiorkor? Now, this again is a very important question. Kwashiorkor marasmus for your FMG exam. So, I have specifically chosen 3-4 questions on malnutrition because this is again a very important marker. Good appetite and a hungry child. So, this is always an indicator that the child has marasmus. Monkey face appearance is again a child having marasmus. A child having irritability and an apathetic look. This is a child who has kwashiorkor, mental changes. Yes, mental changes. Child with severe wasting of muscles is again marasmus. So the only thing that is seen in children with kwashiorkor is irritability and apathetic look, which means mental changes. I've told you growth retardation plus mental changes, growth retardation plus mental changes plus edema. This is a triad that you see in children with kwashiorkor. So growth retardation, mental changes and edema is a triad that is seen in children with kwashiorkor. So these mental changes include this apathy, irritability. This is all the mental changes. And alert kind of a look goes more in favor of a child having marasmus. Edema goes in favor of kwashiorkor. Sugar baby, fat sugar baby appearance. Again a question of FMG, recall question. But in the case of marasmus, you have a more wasted kind of an appearance. Then apathy, irritability, mental changes again goes in favor of kwashiorkor. Alertness goes in favor of marasmus. Poor appetite, anorexia goes in favor of kwashiorkor. A voracious appetite, eagerness to eat goes in favor of marasmus. So which of the following? Then skin changes, hair changes go in favor of kwashiorkor. While relatively less chances of skin changes and hair changes goes in favor of marasmus. And yes, as correctly said, primarily protein deficiency is kwashiorkor, while primarily calorie deficiency is marasmus. Question number 8 says a baby is delivered. A baby is delivered at 29 weeks gestation and is currently admitted in the NICU. A group of medical students are evaluating the case. So the baby is 29 weeks gestation. The baby is 29 weeks gestation and the baby is delivered and is currently admitted in the NICU. A group of medical students are evaluating the case. So they are asking the medical students can expect all of these findings in this preterm baby. So this is clearly a case of a preterm baby. So he's basically trying to ask which of the following will not be a finding, because he's saying all of the following can be seen except. So basically he's trying to ask which of the following is not a feature of a preterm baby. Yes, deep sole creases. Deep sole creases are usually a feature of term and post-term babies. Plenty of planigo is a feature of preterm baby. Lanigo are the fetal hair. So plenty of lanigo is preterm baby. Slow elastic recoil of the ear, preterm babies. So because the ear cartilages are not there, so when you press the ear, it will only slowly go back to its original position. Again, a feature of a preterm baby. Then thin red skin, again a feature of preterm babies. In term and postterm babies, you usually have more desquamated skin, dry skin. But preterm babies have thin red skin. Their sole creases are very, very superficial or sometimes absent. The fetal hair, lanigo, will be plenty over the forehead, over the body. Their skin will be very thin and will be dark red in color. If you press their ear, because of the deficiency of the ear cartilages, the ear will only slowly go back to its original position. So all of these are features of preterm babies. Preterm baby means a baby who is delivered earlier than 37 weeks of gestation. So 37 weeks earlier than that is preterm, 37 to 42 weeks is term, and a baby born after 42 weeks is postterm baby. Postterm babies have desquamated skin, dry skin. Postterm babies have long nails. Postterm babies often are meconium stained because most of the postterm babies have some degree of breathing difficulty intrauterine. So they pass meconium because of that in the intrauterine life. So when a postterm baby is delivered, many times the postterm baby will be stained with meconium stained liquor. So these are features of postterm babies. So please remember, very, very important topic for your exams is difference between preterms and terms postterm babies. Coming to question number 9, during routine examination of an infant, the pediatrician is checking the primitive neonatal reflexes. So I've told about primitive neonatal reflexes in my classes. He will be concerned if the reflex shown in the image is persisting beyond what age. So what is the reflex that you are seeing? You are seeing a Moro's reflex. What is the reflex you are seeing? You are seeing a Moro's reflex. And what should be the timing of disappearance of the Moro's reflex? Let me see what your answer is. What should be the timing of disappearance of the Moro's reflex? Yes, correct. The answer should be 6 months. Because Moro's reflex normally should disappear by 3 to 6 months. I've told about these reflexes. One is the grasp reflex. Then you have the rooting reflex. Then you have the Moro's reflex. Then you have the asymmetric tonic neck reflex. So the timing of disappearance of these reflexes. Timing of disappearance of these reflexes. Grasp reflex disappears by about 3 months. Rooting reflex disappears by about 1 month. Moro's reflex disappears by about 3 to 6 months. So if Moro's is persisting beyond 6 months, it is abnormal. And similarly, asymmetric tonic neck reflex disappears by 5 to 6 months. So if Moro's reflex is persisting beyond 6 months, it is abnormal. It is considered abnormal. As I told you, these are primitive reflexes. Primitive reflexes means neonatal reflexes which appear in the intrauterine life. And they disappear after birth because they are primitive. They have to disappear after birth. So these primitive neonatal reflexes, they gradually disappear after birth. They are suppressed by the more advanced part of the brain, which is the frontal part of the brain, the cerebral cortex. So as the cerebral cortex matures after birth, the cerebral cortex causes suppression of these primitive reflexes. So these primitive reflexes which have appeared during the intrauterine life, they start disappearing after birth. So if the reflex is persisting beyond the time it should disappear, it is abnormal. That means the problem was somewhere in the brain. It was not able to suppress those reflexes. So by seeing whether these primitive reflexes have disappeared or not, you are indirectly trying to see whether the brain of the child is normal or not. So it is basically a non-invasive way of evaluating the brain of the child. Naturally, the reflex is persisting and it has not disappeared after birth, the time it should disappear. That means there is a problem in the frontal part of the brain, the cerebral cortex. It is not able to suppress these reflexes. Parachute reflex never disappears. Yes, it's a reflex which appears after birth. So it's not a primitive reflex. And parachute reflex never disappears. It is known to persist throughout life. So which reflex is not a primitive reflex? Parachute reflex is one of the reflexes which is not primitive. There are other also, but parachute reflex is one reflex which is not primitive. Then another question which is on neonatal resuscitation. During the resuscitation in a preterm newborn baby who is delivered at 36 weeks of gestation, oxygen concentration to be provided with positive pressure ventilation is. So when we start ambu bags, now one part of the ambu bag can be connected to the oxygen source. Now the question is, when I'm starting ambu bag in the baby during a neonatal resuscitation, should I apply oxygen or should I not apply oxygen during neonatal resuscitation? Because as I've told in my classes, if oxygen is given in very high concentration without monitoring, then it can be very dangerous. Now you have to note what is the baby's age. The baby was delivered at 36 weeks of gestation. So as I've told in my classes, some of you are wrong, some of you are correct. As I've told in my classes, that if a baby is born earlier than 35 weeks of gestation, in that case, 21 to 30% oxygen is needed. But if a baby is born at 35 weeks gestation or more than that, only room air is enough. So this is the guideline. If a baby is born earlier than 35 weeks of gestation, 21% to 30% oxygen is needed. So many of you are answering B. 21 to 30% is if a baby is born earlier than 35 weeks. See, our case, the baby is born at 36 weeks of gestation. So he will come in the second category, this category. And if a baby is born at 35 weeks plus, in that case, 21% oxygen. So those who have answered room air, I think only one case where I can see room air. In all other cases, they have given the answer as B. No, answer is not B. According to me, the answer is A. So you need to revise your notes properly again. Exams are coming. Although I think you have prepared well, but sometimes what happens is there are very, very small clues in the question, which you should be very well prepared. Just see what the child's maturity is. It is 36 weeks of gestation. 36 weeks of gestation will come here. Below 35 weeks, it will be 21 to 30% oxygen. But if a baby is born at 35 weeks plus, then only room air is enough. You don't need to provide any extra oxygen with the risk that there might be injury to the lungs. I called it as bronchopulmonary dysplasia. So remember for your exams, 21% for 35 weeks plus and 35 weeks, and 21 to 30% for children who are less than 35 weeks. So because in our case it is 36 weeks, so the correct answer should be room air. Coming to question number 11. Question number 11 says all of the following cyanotic congenital heart disease in children are associated with pulmonary plethora except. हाँ, बहुत डेप्थ तक सोचना पड़ेगा, तो डेप्थ पे नहीं सोचोगे तो एग्जाम कैसे क्लियर करोगे? Okay, so what is pulmonary plethora? Pulmonary plethora. What is meant by pulmonary plethora? I told you there are two terms. One is pulmonary oligemia. When I say pulmonary oligemia, it means decreased pulmonary blood flow. Decreased pulmonary blood flow. But when I say pulmonary plethora, it means increased pulmonary blood flow. So he's saying all of the following cyanotic congenital heart diseases are associated with increase in the pulmonary blood flow except. So where pulmonary blood flow is not increased, pulmonary blood flow is in fact decreased. So I told in my classes that cyanotic congenital heart diseases, I don't think this is a question which you should mark wrong, because I have in detail discussed about congenital heart disease in my classes. So those who have attended my classes, I don't think you should mark this question wrong. It's no chance, because I've discussed congenital heart diseases in great detail in my classes. I mean, in much more depth than what you require for your FMG. In fact, whatever I told in my classes, I believe you can use those those notes for your NEET PG preparations also, once you clear your FMG. So I told cyanotic congenital heart diseases are divided up into two broad categories: decreased pulmonary blood flow, which means pulmonary oligemia, and increased pulmonary blood flow, which means pulmonary plethora. Decreased pulmonary blood flow further are divided up into those with RVH and those with LVH. So decreased pulmonary blood flow with RVH is TOF, and decreased pulmonary blood flow with LVH is tricuspid atresia. So both TOF and tricuspid atresia are actually decreased pulmonary blood flow, which means pulmonary oligemia. You don't need to redraw this. I've drawn this in my classes, so must have made notes from them. Increased pulmonary blood flow is seen in transposition of great arteries. It is seen in truncus arteriosus. It is seen in total anomalous pulmonary venous return. It is seen in hypoplastic left heart syndrome. So these are decreased pulmonary blood flows and increased pulmonary blood flows. As I told you, when we say decreased pulmonary blood flow, it means pulmonary oligemia. And when I say increased pulmonary blood flow, it means pulmonary plethora. Now coming back to my question, he's saying all of the following are associated with pulmonary plethora except, which means he's saying which is not associated with increased pulmonary blood flow. Answer is TOF. As you can see, TAPVR, TGA and truncus arteriosus, they all are associated with increase in the pulmonary blood flow. So the only one which is associated with decrease in the pulmonary blood flow is TOF. So please, for your exams, be very, very careful about what questions they are asking. अभी there was one student who said, बड़ी ध्यान से पढ़ना पड़ेगा, बड़ी ध्यान से देखना पड़ेगा. There was a student who said, we have to be very careful in seeing each and every line of a question. This is correct. You're going to be doctors, and it is very important that you need to be very, very clear about each and every line of a question before you answer that question. Even one line not properly read, you can mark the answer wrong to that question. Yes, diseases starting with cyanotic heart disease T. Question number 12. So again, in a child with a cyanotic congenital heart disease, presenting with cyanosis immediately after birth, reduced pulmonary blood flow, and ECG showing a left ventricle hypertrophy. Now you should be able to tell. I've already told you here. He's saying decrease pulmonary blood flow, reduce pulmonary blood flow, and ECG showing a left ventricle hypertrophy. So I told you, cyanotic heart disease, reduced pulmonary blood flow. With the right ventricle hypertrophy is tetralogy of Fallot, and with the left ventricle hypertrophy is yes, tricuspid atresia. So now where is it difficult? Cyanotic heart diseases with reduced pulmonary blood flow can either be TOF or a tricuspid atresia. So when I say a cyanotic heart disease with reduced pulmonary blood flow with the right ventricle hypertrophy, then you say TOF. And when I say cyanotic heart disease with reduced pulmonary blood flow with the left ventricle hypertrophy, you say tricuspid atresia. Yes. And TGA, TAPVR, truncus arteriosus, they all are associated with increase in the pulmonary blood flow. So now you promise you won't make any wrong answer in the exam. If a question on congenital heart diseases are asked, you have to promise that. Please remember the questions that are asked on congenital heart diseases in FMG exams, as far as I have seen in the last few years, they are very, very simple. They can be easily answered if you are just a little careful about what questions they are asking. Don't be in a rush to answer the question. Little more difficulty in answering questions on congenital heart disease is when you prepare for your NEET PG exam. So in NEET PG and ICT, yes, the questions are a little more difficult. Their approach is different. But at least for FMG, you have to promise these are very simple things. Just remember that table of congenital heart disease classification that I told you, that is good enough for your exams. Very good. So promise you will not make any mistake. Okay. Coming to question number 13. So again, a very simple question. A baby is brought to the emergency with severe cyanosis. Just chest X-ray is shown. Now chest X-ray is very clear. This is a very typical type of a chest X-ray. He's saying which is the most likely congenital heart disease which has this typical presentation. So what type of a X-ray presentation is this? What type of X-ray presentation is this? This is very, very simple. What type of X-ray presentation is this? Let me see. So let us see. What type of an X-ray presentation is this? Which type of heart you are seeing? You are seeing very clearly a heart which is not boot-shaped heart. In boot-shaped heart, it will be something like this. Don't confuse this with a boot-shaped heart. Apex will be up. This will be boot-shaped. This will be boot-shaped. But this is egg on a string appearance. This is egg on a string appearance. And egg on a string appearance is seen in TGA. Don't confuse it with a boot-shaped heart. Boot-shaped heart, the apex of the heart will be up. In egg on a string appearance, the apex of the heart will be sloping down. So boot-shaped heart will be seen in TOF. But egg on a string appearance is seen in TGA. Then snowman's heart or figure of 8 appearance is seen in TAPVR. Box-shaped heart is seen in Epstein's anomaly. And sign of 3 is seen in cooptation of aorta. So these are the X-ray pictures that you should remember for your exams. Yes, boot-shaped heart is also called as Cour and Sabot. So since what you are seeing on the X-ray, the picture that you are seeing is an egg on a string appearance. Therefore, in our case, the answer is transposition of great arteries. Coming to the next question, question number 14. So question number 14 says a newborn with fever, irritability, and intermittent stuporous posturing is diagnosed with neonatal meningitis. So there is a child who has been diagnosed with neonatal meningitis. Remember, that is a newborn who has been diagnosed with meningitis. He's saying all of the following can be possible etiological causes for neonatal meningitis except. So which of these is not a cause of neonatal meningitis? So if you remember in my classes, I've told you meningitis caused in children between birth till 2 months, and then meningitis caused in children above 2 months. So when we talk about neonatal meningitis, the choices are very simple. It is group B streptococcus worldwide, E. coli in India, Klebsiella, Staphylococcus aureus, and Listeria. Apart from this, the important causes of meningitis, which includes H. influenza, which includes Streptococcus pneumonia, and which includes meningococcus, they are known to cause meningitis after the age of 2 months. Yes, so H. influenza will not be a cause of neonatal meningitis because as you are seeing, H. influenza, Streptococcus pneumonia, and meningococcus usually are causes of meningitis after the age of 2 months. For neonatal meningitis, just remember these causes: Group B Streptococcus, E. coli, Klebsiella, Staphylococcus aureus, Listeria. Just remember these causes, 5 causes of neonatal meningitis: Group B Streptococcus, E. coli, Klebsiella, Staphylococcus aureus, and Listeria. Worldwide, the most common cause is it is Group B Streptococcus. But in India, the most common cause of neonatal meningitis is E. coli. So E. coli is the most common cause of neonatal meningitis in India. We are not talking about infant meningitis. We are talking about neonatal meningitis. Neonatal period is the period which occurs in the first 28 days of life. So we are talking about neonatal meningitis, not infant meningitis. So which is worldwide the most common cause of neonatal meningitis? Group B Streptococcus. But which is the most common cause of neonatal meningitis in India? It is E. coli. So if you see our options, Staph aureus, Listeria, E. coli, they all are causes of neonatal meningitis except for H. influenza, which causes meningitis usually after the age of 2 months. So it is not a cause of neonatal meningitis. इसमें confusion नहीं होना चाहिए. There should be no confusion here. What confusion do you have? Remember the causes: Group B Streptococcus, E. coli, Klebsiella, Staph, Listeria. First, जितने भी enterobacteriaceae हैं, most of the enterobacteriaceae, E. coli, Klebsiella, they all will cause meningitis in the neonatal age group. The classical causes of meningitis, staph, which is H. influenza, Streptococcus pneumonia, and meningococcus, will be causes of meningitis after the age of 2 months. Infant meningitis will be meningitis after 2 months. So if you are asked infant meningitis, after 2 months, whatever are the causes of meningitis, they will be infant meningitis causes: H. influenza, Streptococcus pneumonia, meningococcus. But as far as I know, there is no term which is referred to as infant meningitis. Neonatal meningitis is important, but there is no term called as infant meningitis. Okay, you can say H. influenza is for infant meningitis. It is not for neonatal meningitis. I don't know which book you are referring to, infant meningitis. There is no term as infant meningitis. We have neonatal meningitis, which is a specific term because meningitis in newborns is little different from meningitis in the remaining parts of childhood. Coming to question number 15. Question number 15 says, a newborn is again, so the question is again on a newborn. A newborn is being evaluated for bilaterally enlarged kidneys with multiple small cysts in the cortex and the medulla. So they are bilaterally enlarged kidneys. Bilateral. So this is again a clue. Bilaterally enlarged kidneys with multiple small cysts. So this appears to be a case of a congenital cystic disorder of the kidney. Congenital cystic disorder of the kidney. So there are two congenital cystic disorders of the kidney which are important. There are many which are there, but two which are important. As I told you, one is multicystic dysplastic kidney. One is multicystic dysplastic kidney. And the other is polycystic kidney disease. Polycystic kidney disease. Now, as I told you, multicystic dysplastic kidney is usually unilateral, affects one kidney, while polycystic kidney disease is usually bilateral. So this appears to be a case of a polycystic kidney disease because it says bilaterally enlarged kidneys. Bilateral. Bilateral means both kidneys are affected. It cannot be multicystic because multicystic dysplastic kidney will affect one kidney only. So this appears to be a case of polycystic kidney disease. Sometimes polycystic kidney disease, because of the number of cysts that are present, on ultrasound may show a salt and pepper appearance. That means those cysts may appear as black spots in a white background, which appears as salt and pepper appearance. But anyway, salt and pepper appearance, forget it. Important thing to remember is if it is bilateral kidney involvement, it is more likely to be polycystic kidney disease. If it is a single kidney involvement, it is more likely to be a multicystic dysplastic kidney. And if it is a polycystic kidney disease, then obviously which is the other organ to get affected? It is liver fibrosis. So yes, C is the correct answer. It's autosomal recessive polycystic kidney disease. Some students have given D as the correct answer. D as the answer. I don't know why they are thinking of D. Brain angiomatosis is never seen in polycystic kidney disease. As I told, in polycystic kidney disease, there is mutation of PKHD1 gene. So PKHD1 gene. PK stands for polycystic kidney. Polycystic kidney. And HD stands for hepatic disease. So liver fibrosis is likely to be present in these children. Mayank has said angiomatosis of the brain. Why? I don't know. But angiomatosis of the brain is not seen in these cases. And in fact, there are some who have given answer as A also. Where does A come from? Why will there be cysts in the lungs? They will be cysts in the liver. This is a polycystic kidney disease. So cysts are not present in the lungs. Cysts are present in the liver. I don't think this was a difficult question. This was a much simpler question. Only thing is, rather than directly asking the question, they are asking a question in a slightly indirect manner. Please try to expect now these type of questions. Now the papers that we are seeing in the last 1 or 2 years FMG are not very simple. Last paper also was not simple. So now the papers that they are asking is slightly indirect questions, which requires a little thinking. That a classical recall type of questions. What is the most common? What is the least common? Which is the largest? Which is the smallest? That is now less likely to be asked. There might still be some questions like this, but they are less likely to be asked. More likely to be asked are indirect questions. So they could have very simply asked a polycystic kidney disease, which is the other organ that is affected. But first, they want to see whether you are able to identify that this is a polycystic kidney. So they intentionally put bilaterally enlarged kidneys with cysts. So now you realize this is not a multicystic dysplastic kidney, it's a polycystic kidney disease. Then you see polycystic kidney disease, autosomal recessive, mutation in PKHD1 gene. Okay, so what is HD? Hepatic disease. So which is the other organ that will be affected? Liver fibrosis. So don't be confused with autosomal dominant. No, don't be confused. We are talking about a newborn. So how can you be confused with autosomal dominant? This is autosomal recessive polycystic kidney disease. Coming to question number 16. Question number 16 says, in a 5-year-old child with nephrotic syndrome and persistence of proteinuria despite 6 weeks of full dose prednisolone, what is this condition called as? When in a child with nephrotic syndrome, proteinuria is persisting despite 6 weeks of full dose prednisolone. What is this condition called? This condition is called as a steroid resistant nephrotic syndrome. So this is called as a steroid resistant nephrotic syndrome. When the child's proteinuria persists despite 6 weeks of full dose daily steroid therapy, we call it as a steroid resistant nephrotic syndrome. And what is the drug of choice for a steroid resistant nephrotic syndrome? The drug of choice for a steroid resistant nephrotic syndrome is, again, why am I getting answer B? It appears as if you have not read my notes. I hope those students who are answering answer as B are those students who have not attended my classes, because in my classes, I don't think students should miss out on this answer. I very clearly told steroid dependent nephrotic syndrome, drug of choice levamisole. Steroid resistant nephrotic syndrome, drug of choice cyclosporin or tacrolimus. I don't know why cyclophosphamide comes in the picture. Cyclophosphamide can never be the picture. Yes, cyclosporin or tacrolimus is the answer. So I sincerely hope, I don't know if most of you are attending this session. Are you the students who have attended my classes? Yes, if you have attended my classes, because I normally take most classes which are in Delhi, and in outstation I take the class in Jaipur. So there are some other outstation classes in MIST also, which I know. So I don't know if you have attended my class or not, but if you have attended my classes in MIST, then it is very clear. Steroid dependent nephrotic syndrome, the drug of choice is levamisole. Steroid resistant nephrotic syndrome, the drug of choice is cyclosporin or tacrolimus. Finish. No cyclophosphamide here. So cyclophosphamide in fact is never the drug of choice in steroid dependent or steroid resistant. In some steroid dependent nephrotic syndrome, cyclophosphamide may become the drug of choice if there are severe steroid toxicities, but leave that, it is complicated. Just remember the main drug of choice for a steroid dependent nephrotic syndrome is levamisole. The drug of choice for a steroid resistant nephrotic syndrome is cyclosporin or tacrolimus. Here tacrolimus is not given, so the answer is cyclosporin. Yes, so if there is a persistence of proteinuria despite 6 weeks of full dose steroids, then we call it as a steroid resistant nephrotic syndrome. What is a steroid dependent nephrotic syndrome? I told steroid dependent nephrotic syndrome is when there are relapses of proteinuria. When the child is shifted to alternate steroids or within 2 weeks of stopping the steroids. Coming to question number 17. So question number 17 says a 3-day-old newborn with hypoxic ischemic encephalopathy. HI is hypoxic ischemic encephalopathy. a 3-day-old newborn with hypoxic ischemic encephalopathy is brought to the emergency in seizures. The child's APGAR score was 3 and 4 at 1 and 5 minutes after birth. Which of the following anti-epileptic drugs should the neonatologist choose to abort these seizures? So now again, it is very important to remember we are talking about a newborn who has come to you with fit, because your answer will depend upon whether we are talking about a neonatal seizure or we are talking about a childhood seizure. Because if we are asking about neonatal seizure, your drug of choice will be different. If we are asking about childhood seizure, drug of choice is different. And for a neonatal seizure, yes, that for a neonatal seizure, the drug of choice is phenobarbital. So for a neonatal seizure, the drug of choice is phenobarbital. So for a neonatal seizure, the drug of choice is phenobarbital. But for a childhood seizure, the drug of choice, as I told you, is either IV midazolam or IV lorazepam. So it is very important that you give the answer based upon what they are trying to ask. If they are trying to ask the drug of choice for a neonatal seizure, the answer should be phenobarbital. Most of you have answered phenobarbital. But if they are asking about drug of choice for a childhood seizure, then the drug of choice is either IV midazolam or IV lorazepam. There is one answer given B also. B is not the answer. Valproate is never the drug of choice either for a neonatal seizure or for a childhood seizure. In case a child does not respond to neonatal seizures with phenobarbital, then you can give other drugs such as phenytoin, or you can think of levetiracetam, or sometimes even think of drugs like lidocaine, or sometimes think of even pyridoxine. Vitamin B6 given in high doses can be given for children who have refractory neonatal seizures. So intravenous phenytoin, intravenous levetiracetam, intravenous lidocaine, intravenous pyridoxine, vitamin B6. For pregnancy and children valproate is not contraindicated. Children valproate is given. It is not contraindicated. Please remember this. It's not contraindicated. But for pregnancy, yes, valproate should be avoided. Right? So phenytoin, levetiracetam, lidocaine, pyridoxine, these are drugs of choice that you use for refractory neonatal seizures. And which are the drugs of choice you use for refractory childhood seizures? For refractory childhood seizures, which are the drugs of choice? So you can give again IV phenytoin if the child is not responding, or IV levetiracetam, or you can even think of giving valproate here. So thank you, Asif. I hope you have found some benefit before you are labeling me as the best. There are many other pediatric teachers, faculties who are very, very good. So I don't think I am the best, but I do think that yes, if you have attended my classes and made notes properly, then definitely there will be benefits. I may be a small contributor to you clearing these exams. So that is what I think. Right? Okay, coming to question number 18. Question number 18 says a child has been diagnosed with slow growing brain tumor which is located near the pituitary area. So there is a slow growing brain tumor. So there is a slow growing brain tumor. So there is a child who has been diagnosed with a slow growing brain tumor located near the pituitary area. So now again, the catch in the question is pituitary area. So a brain tumor located near the pituitary area. The pituitary area is known as the sella turcica. And if there is a tumor which is lying, near the sella turcica and starts causing calcification, so that calcification will be called as suprasellar calcification. The area where this tumor is rising, so the area where this tumor is present is known as the sella turcica area, the pituitary area. And because it is present near the pituitary area, it can cause calcification in this area. So this calcification is known as suprasellar calcification. So which is the brain tumor which is most likely to present with the suprasellar calcification? Yes, it is a craniopharyngioma. Overall most common brain tumor in children. So in children, overall most common brain tumor is cerebellar astrocytoma. Overall most common malignant brain tumor. Overall most common malignant brain tumor is a medulloblastoma. So overall most common brain tumor is cerebellar astrocytoma. But cerebellar astrocytoma is benign. So if you are asked overall which is the most common malignant brain tumor, the overall most common malignant brain tumor is medulloblastoma. So the catchword here is malignant. Yes, overall most common malignant brain tumor is medulloblastoma. Then most common brain tumor of infants. Most common brain tumor of infants is a choroid plexus tumor. Overall most common brain tumor of infants is choroid plexus tumor. So if someone asks you which is overall the most common brain tumor of infants less than 1 year. So overall most common in children is cerebellar astrocytoma. But in infants the most common brain tumor is choroid plexus tumor. And then if they ask you which is the most common brain tumor which causes suprasellar calcification. So because this brain tumor is present near the pituitary area, answer is craniopharyngioma. So our answer should be craniopharyngioma. So repeat with me. Overall most common brain tumor, cerebellar astrocytoma. But less than 1 year most common brain tumor, infants, it is choroid plexus tumor. Then most common malignant brain tumor, medulloblastoma. And most common brain tumor which is present near the pituitary area and causes suprasellar calcification is a craniopharyngioma. Question number 19 says, in a 10-month-old infant, with fever and wheezing episode. So this again, the clue to the question is wheezing. It's very, very important to be able to identify the clues. You cannot make an answer wrong in the question if you are able to identify the clue. You open a lock with a key. So the key is the most important. The moment the key is in the lock, the key is correct, you open the lock. Similarly, here the lock is the question. The key is that clue with that question. If you are able to put the key correctly in the lock will open. So you can understand this question that is given to you is a puzzle, is like a lock. Only thing is in that lock you have to identify the key. Correct key put in the lock, the question will easily open up and the answer will be very clear. Here, what is the clue? The clue will be wheezing episode. So if there is a stridor episode, so stridor means upper respiratory problems. But when they say wheezing episode, it means lower respiratory problems. And for lower respiratory problems, the most common reason is obviously, yes, RSV. RSV. This is clearly a case of bronchiolitis. This is clearly a case of bronchiolitis. Bronchiolitis, first wheezing of infants. First wheezing of infants is bronchiolitis. This is all that you have to remember for your exams. Only thing to remember for your exams is first wheezing of infants is bronchiolitis. Recurrent wheezing is asthma. But first wheezing of infants, which means there has never been a wheezing episode. Wheezing means those whistling like sound coming from the mouth. It usually indicates problem is in the lower respiratory tract. Strident means a noisy breathing. It means a problem is in the upper respiratory tract. So croup, epiglottitis, they present with stridors. Bronchitis, bronchiolitis, pneumonias, they present with wheezing. Lower respiratory tract is affected. And first wheezing in an infant is bronchiolitis. Bronchiolitis is never seen usually after 2 years of age. Most cases of bronchiolitis, even in the first 2 years, most cases of bronchiolitis will be in the first year of life. I think if a question is given for bronchiolitis in your exams, it will always be an infant. So I think the first clue you will identify in the question will be that the question will be talking about an infant. The second clue, they will be asking about wheezing. Remember, infant with wheezing usually means bronchiolitis. And the third clue is no previous such history present. No previous such history present means first wheezing. So now everything falls in place. First wheezing, infant, it is bronchiolitis. And what is the most common cause of bronchiolitis in children? It is respiratory syncytial virus. Parainfluenza viruses are the most common cause of croup in children. H influenza is the most common cause of epiglottitis in children. I think in adults, the more common cause of epiglottitis is streptococcus pneumonia. But in children, the most common causes of epiglottitis are H influenza type B. The most common cause of croup in children are parainfluenza viruses. Yes, first wheeze is always bronchiolitis. Asthma is recurrent wheeze. Very good. So most of you are talking the things that I discussed in my class. So I can very easily, from the things that some of the students are mentioning, very easily I can understand that these are the students who have attended my class, because these are the clues that I give in my class. First, wheezing, infants, bronchiolitis. And bronchiolitis means RSV, respiratory syncytial virus. A 13-year-old boy is brought to the neurology clinic with a history of early morning repetitive jerking. So again, the clue here is early morning repetitive jerking. There is early morning repetitive jerking, which means a seizure that has resulted in objects dropping from the child's hands. Objects dropping from the child's hands. So there was a seizure in the morning that resulted in objects dropping from the child's hand. The second clue is that the child also has a family history positive. So his brother has also been diagnosed. So there is a family history that is positive. This is the second clue. The third clue is EEG shows 4 to 6 hertz spikes and wave pattern. This is again a very typical EEG pattern. A 3 hertz spike and wave pattern on EEG shows that the child has absent seizures. A disorganized EEG, which is called as hypsarrhythmia. Disorganized EEG, which means hypsarrhythmia, indicates a child has infantile spasms. And a 4 to 6 hertz polyspikes, 4 to 6 hertz polyspikes and wave pattern means the child has juvenile myoclonic epilepsies. Juvenile myoclonic epilepsies. So our patient most likely has a juvenile myoclonic epilepsy. First clue that EEG is very typical, 4 to 6 hertz polyspike and wave pattern. And in our question also, polyspike and wave pattern is there. The second clue is that in our patient, so because I'm talking about juvenile myoclonic epilepsy, Jan syndrome. So juvenile means adolescent. So just cross check. Is the patient adolescent? Yes, he's an adolescent. Then the next clue, family history. 50% of these children has a positive family history. So positive family history present in these cases. And early morning seizure, that is usually present in juvenile myoclonic epilepsies. Juvenile myoclonic epilepsies, a very easy clue is that most of these occur in morning hours. So age of the child matches with juvenile myoclonic epilepsy. Early morning seizure matches with juvenile myoclonic epilepsy. Then the child has a positive family history, matches with juvenile myoclonic epilepsy, and a typical EEG matches with juvenile myoclonic epilepsy. And therefore, what should be the drug of choice for juvenile myoclonic epilepsy? It is sodium valproate. ACTH is the drug of choice for infantile spasms. Sodium valproate is a drug which can be given for children who have juvenile myoclonic epilepsies. It is also given as a drug of choice along with ethosuximide, or not along with either ethosuximide or valproate is also the drug of choice for children who have absent seizures. Coming to question number 21. Question number 21 says an 8-week-old child is brought with persistent vomiting starting from about 6 weeks of age. Initially intermittent after a few feeds and at the time of presentation after each feed. So this was a child who is a 8-week-old child. So around 2-month-old child. The history is that the child started having vomitings when the child was about 6 weeks of age. So the vomiting never started from birth. The child started having vomiting starting from about 6 weeks of age. Initially, those vomiting episodes were intermittent. That means sometimes they used to happen, sometimes it did not used to happen. But later, when the child was brought by the mother to the clinic, the mother was very worried that the child is now having vomitings almost after each feed. The child also appears to have abdominal contractions that are visible contractions in the abdomen. And there is also a olive-shaped mass. So which is the condition we are talking about? Yes, we are talking about a congenital hypertrophic pyloric stenosis. A congenital hypertrophic pyloric stenosis. That means the pylorus part of the stomach. The pylorus part of the stomach, the gastric outlet, we call it as this part. The pylorus part of the stomach, the gastric outlet, is usually thickened starting from the time of birth. We also have an acquired hypertrophic pyloric stenosis. Drugs like macrolides, erythromycin is the most notorious. So drugs like macrolides can cause acquired hypertrophic pyloric stenosis. That's not congenital. But here we are talking about congenital hypertrophic pyloric stenosis. They usually have 3 P's, P, P and P. So first P is peristaltic waves which can be seen in the abdomen. Second P is projectile vomitings. So the child will have projectile vomitings, but usually the projectile vomiting will not start from birth. It will start from about 6 weeks of age. And the third P is a pyloric mass. So that thickened pylorus appears as a pyloric mass which is olive shaped. So if someone asks you which is the disorder which is associated with 3 P's, peristaltic waves, projectile vomitings and pyloric mass, it is hypertrophic pyloric stenosis. The peristaltic waves does not move from right to left, they move from left to right. So left to umbilicus, that's the direction of the movement of the Peristatic waves, non-bilious vomitings. Yes, peristatic waves from left side to right side. And what is the investigation of choice? The investigation of choice is ultrasound abdomen. I think this is taught most commonly in surgery, so I won't go into detail, but it is something which is very important pediatric question. You may take it as a part of a pediatric surgery question, or you may take it as a part of a pediatric medicine question, but it is a very, very important pediatric question. What is the best way to diagnose a hypertrophic pyloric stenosis? Seeing the thickness of the pylorus on the ultrasound of the abdomen. In fact, the thickness of the pylorus also increases on the ultrasound, and the length of the pylorus also increases on the ultrasound. So pylorus length and pylorus thickness, they both increase on ultrasound. That is the investigation of choice for hypertrophic pyloric stenosis. I don't know why many happy birthday messages are being given to me. It is not my birthday, so I don't know why I'm repeating it. Yes, it's Dr. Vineet's topic, so I will leave it here only. Coming next to question number 22. A child with 8 to 10 episodes of watery diarrhea, poor skin turgor, dry oral mucosa, lethargy, and poorly accepting feeds. What is the treatment of choice? So this is a child who is in dehydration. Now there are two things that you need to see when the child presents to you in dehydration. Is the child alert? The child appears drowsy. The child is alert. The child appears irritable. The child appears drowsy or unconscious. So if the child appears to be very alert, then this is most likely a child in no dehydration. If the child appears to be irritable, the child appears to be most likely in some dehydration. And if the child appears to be drowsy or unconscious, then the child most likely is in severe dehydration. So this is the first clue. Is the child alert? Yes, then it is no dehydration. Is the child irritable? Yes, then it is some dehydration. Is the child drowsy? The child is in severe dehydration. Then give some water to drink. See how the child is drinking water. See how the child is drinking water. The child does not appear to be thirsty, not thirsty at all. So when you are giving water to the child to drink, he does not appear to be thirsty. He will drink some water, but otherwise he does not appear to be thirsty. So this is a child who is in no dehydration. The child appears to be very, very thirsty. He is drinking water very, very eagerly. This is some dehydration. And the child is refusing the water. He is not refuses the water to drink or is not able to drink properly. This is in severe dehydration. I think for your exams, these are the two main clues. These are the two main clues that you should be able to identify. Sorry, not this and this. These are the two main clues that you should be able to identify. First, consciousness level of the child. And second, how is the child drinking water? These are the two main clues by which you will be able to identify the child is in which category of dehydration. Low dehydration, some dehydration, severe dehydration. And yes, the remaining part will be then seeing the skin turgor, dryness of the oral mucosa, dryness of the eyes. So all of that is secondary. But the most important way by which you will be able to identify is the consciousness level of the child and how the child is drinking water. Now if you come back to our question, the child has dry oral mucosa. So obviously he cannot be no dehydration. He appears to be lethargic. So he's not irritable. He's lethargic, drowsy. And he's poorly accepting feeds. So this again goes in favor of child having severe dehydration. And for severe dehydration, the drug of choice is, yes, ringalactate. But why this cannot be the answer? This will be the correct answer only when you are giving the child IV fluid in malnutrition. So when you're treating dehydration in malnutrition, then ringer lactate and 5% dextrose will be given. Now here, please remember, nowhere have they mentioned that the child appears to have malnutrition. Now there have been many C's that are seen. Nowhere in the question they have mentioned that the child is malnutrition. Just see, a child with 8 to 10 episodes of watery diarrhea, poor skin turgor, dry oral mucosa, lethargy. So this is purely a child presenting with dehydration, which is because of diarrhea. Where is it written? This is a malnourished child. If it is not a malnourished child, all dehydration episodes which are severe dehydration need to be treated with plain ringer lactate. But in case there is a malnutrition with dehydration episode, particularly in a child who is in shock, then you give ringer lactate and 5% dextrose. So please remember, ringer lactate and 5% dextrose is only when we are talking about malnutrition. Here there is no case of malnutrition. But dextrose osmotic diarrhea nikale. So I am not giving dextrose. I am only giving ringer lactate. Where am I saying dextrose? Answer will be ringer lactate only. I hope you have all understood. You have all understood why I am saying here the answer will be ringer lactate, because ringer lactate and 5% dextrose is for the treatment of, see, when we have dehydration management in children, no dehydration is treated with ORS. Some dehydration is treated with ORS, and severe dehydration is treated with IV fluid. And IV fluid of choice is IV ringer lactate or IV normal saline. You can choose from them, but ringer lactate is preferred. Ringer lactate is preferred. But when we are talking about dehydration in a malnourished child, dehydration in malnutrition, then the only case where IV fluid will be required will be severe dehydration in shock. That is the only place where IV fluid is required, and that IV fluid is ringer lactate in 5% dextrose. So ringer lactate in 5% dextrose is only when you are treating severe dehydration in a child who is malnourished. Severe dehydration, that too with shock. All other types of dehydration and malnutrition are treated with ORS, and that also a modified form of ORS. You do not use a standard ORS in malnourished children. And I've clearly explained these things in my classes. So in my question, there is nothing which mentions that the child is malnutrition. Therefore, the correct answer should be plain ringer lactate. Why should we give ringer lactate in 5% dextrose? So my answer will be plain ringer lactate, not ringer lactate in 5% dextrose. Coming to the next question, in a 36-week newborn baby delivered by cesarean section and developing breathing difficulty after birth, most likely pathological mechanism for breathing difficulty. So this is a baby who is a 36-week newborn baby. So I told most common cause of respiratory distress in newborn babies who are delivered earlier than 34 weeks is RDS, respiratory distress syndrome, also called as hyaline membrane disease. But the most common cause of respiratory distress in late preterm babies means babies who are born at about 35-36 weeks, or in term babies, is transient tachypnea of the newborn. In our patient, the baby is 36 weeks. Our case, the baby is 36 weeks. So this baby is a late preterm baby. Late preterm baby. This is a late preterm baby. And what is the second clue? The second clue is that the baby was delivered by cesarean sections. Most of TTNBs are delivered by cesarean sections. Yes, all of you are correct. The answer is This is a case of transient tachypnea of the newborn, which is because of the retention of the fetal lung fluid. The most likely reason why this is TTNB is because this baby is a late preterm baby. Why will a late preterm baby have hyaline membrane disease? Surfactant is normally maximally produced at 34 weeks of intrauterine life. So a baby who is born after 34 weeks is likely to have proper amount of surfactant in his lungs. So why will he have hyaline membrane disease? He's more likely to have a TTNB. And in case somebody asks you, most common cause of respiratory distress in post-term babies, that means after 42 weeks, then it is most likely meconium aspiration. So respiratory distress because of meconium aspiration. So just remember, most common cause of respiratory distress in newborn babies who are born earlier than 34 weeks is RDS. Most common cause of respiratory distress in late preterm babies and in term babies is transient tachypnea of the newborn. And most common cause of respiratory distress in post-term babies. That means babies who are born after 42 weeks. As I told you, post-term means a baby who is after 42 weeks and still inside the mother. So these babies, because of some amount of breathing difficulty, they pass meconium intrauterine. So when they are delivered, they are meconium stained, and some of the meconium may enter into the respiratory tract, blocking the respiratory tract, leading to meconium aspiration syndrome. So because in our case, the case is 36 weeks, so in our case, the answer is TTNB. And what is TTNB due to? It is because of retention of the fetal lung fluid. Coming to question number 24, an infant is delivered to a mother who had a history of poorly controlled type 2 diabetes, and the mother was on metformin. The mother's blood sugar is poorly controlled. Which of these complications in the infants is most specific to maternal diabetes? So most common complication in infants of diabetic mothers and most specific complication in infants of diabetic mothers. So most common complication in infants of diabetic mothers is neural tube defects, and most specific complication in infants of diabetic mothers is sacral agenesis or caudal regression syndrome. So why will there be hypoglycemia here? So most specific complication, yes, is sacral agenesis. Again, why are some of the students answering hypoglycemia? Hypoglycemia is not the most specific complication. The most specific complication seen in infants of diabetic mothers is sacral agenesis, which is also called as caudal regression syndrome. Most common congenital heart defects in these babies is VSD, ventricle septal defects. Most specific congenital heart defect in these babies is transposition of great arteries, and least common congenital heart defect in these babies is atrial septal defects. So most common congenital heart defect in these babies is ventricle septal defects. Most specific congenital heart defect in these babies is transposition of great arteries, and the least common congenital heart defect in these babies is atrial septal defects. Hypoglycemia, large for gestational age, hypocalcemia, small left colon, those are other complications. But if they ask you in the exam which is the most specific complication, then it is sacral agenesis, which is also called as the caudal regression syndrome. So he's clearly asking in this infant which is the most specific complication to the maternal diabetes. So most specific complication to maternal diabetes should be sacral agenesis or caudal regression syndrome. And coming to our last question, question number 25, all of the following are indications of IV dextrose administration in a newborn baby who has hypoglycemia. So neonatal hypoglycemia is defined as blood sugar which is less than 40 milligrams per deciliter. So neonatal hypoglycemia is when the blood sugar is less than 40 milligrams per deciliter. Now, neonatal hypoglycemia can either be asymptomatic or it can be symptomatic. That means either there may be some symptoms, for example, tremors, jitteriness. This is a symptom of hypoglycemia in newborns, jitteriness, or a seizure in a newborn. It may be a manifestation of neonatal hypoglycemia, or a very high pitch cry, or a very low pitch cry. These are some symptoms where a newborn develops hypoglycemia, symptoms of hypoglycemia. But the very strange part is that neonatal hypoglycemia can also be asymptomatic. That means it can be completely without any symptoms. Remember, when neonatal hypoglycemia has symptoms, treatment is always IV. So first we give an IV bolus dextrose and then we start glucose infusion. So IV symptomatic hypoglycemia is always treated in newborns with intravenous solutions. But when the child is asymptomatic hypoglycemia, we try to see what is the blood sugar level before deciding oral or IV. So if the blood sugar levels are only slightly low, which means they are between 20 to 40 milligrams per deciliter, slightly low, then we try oral. That means we try milk. So give milk to the baby and recheck after 60 seconds. That means 1 minute. Recheck blood sugar after 60 seconds. But if the child is having asymptomatic hypoglycemia and the blood sugar is very, very low, which means it is less than 20 milligrams per deciliter, then again the treatment will be only IV. You're getting the point that I'm trying to say. When a child has symptoms of hypoglycemia, no matter how low the blood sugar is, treatment is always IV. But when the child is asymptomatic, that means we routinely were screening a newborn and suddenly we found hypoglycemia. But right now the newborn is not having any symptoms of hypoglycemia. Check how much is the blood sugar. If it is not very low, it is somewhere between 20 to 40. Try giving milk to the baby and recheck blood sugar after 60 seconds. If after 60 seconds we see that the blood sugar has now improved and it is now more than 40 after 60 seconds, now you continue milk only. And in case it still remains less than 40, then IV dextrose. So very easy to understand this. Very, very easy to understand this. See, when a newborn has hypoglycemia, see whether he has symptoms or no symptoms. If he has symptoms, do not check how low blood sugar is. Just less than 40, symptoms, start IV. IV 10% dextrose, first bolus is given, then followed by glucose infusion. But if the child is asymptomatic but had hypoglycemia, check how low is the blood sugar. If the blood sugar is only slightly low, 20 to 40, which means marginally low. So in this case, what we do is give milk to the baby and check blood sugar again after 60 seconds. After 60 seconds, if the blood sugar now becomes more than 40, normal, then continue milk only. But after 60 seconds, if the blood sugar still remains less than 40, then give IV. And if the child is asymptomatic hypoglycemia and the blood sugar is very low, less than 20, then obviously IV is the treatment. So you understand, once more, just repeat after me once more. Hypoglycemia, symptomatic, asymptomatic. Symptomatic, always IV. Asymptomatic, 20 to 40, less than 20. 20 to 40, milk. Repeat blood sugar after 60 seconds. After 60 seconds, blood sugar more than 40, continue milk. Less than 40, IV. Asymptomatic and less than 20 means IV. So what are the indications of giving IV dextrose? Indications. First, IV dextrose is given for all symptomatic hypoglycemia, no matter how low the blood sugar is. Second, it is given for all asymptomatic hypoglycemia, where the blood sugar is very low, which means less than 20. And third, it is given for those cases of those cases of hypoglycemia where initially the blood sugar was 20 to 40 and the child was asymptomatic, but even after giving milk, the blood sugar did not improve and remained less than 40. So these are the three broad indications for giving IV treatment. So which is the indication not for giving IV treatment? That, as I told you, symptomatic and blood sugar less than 20. Symptomatic means don't need to see how much is the blood sugar. Symptomatic means IV. Asymptomatic, blood sugar less than 20, again IV. The only indication asymptomatic blood sugar between 20 to 40, here you will try milk for the baby initially. So the answer here should be D. So I hope you have understood these questions. Please remember the topics that I have given in these questions or topics I want to convey through these questions. They all are very important topics for your exams. I wish you all the best for your FMG exams. Hope this session has been beneficial to you and you were able to derive some benefits from these topics. Those who have attended my classes, definitely this would have been a repetition for them. And I wish you all the best and I hope to see you all successful in the upcoming FMG exams. So thank you very much for attending this session and goodbye.